Joel Topf here with Nephrology Times. I'm here with Dr. Connie Rhee. Dr. Rhee, you've been on a rocket ship recently. You became chief of the nephrology section at the UCLA VA, and then a year later you were CJASN's first female editor. Amazing stuff.
Oh, thank you so much. Your feedback means a lot to me, Dr. Topf. I'm a huge fan of your work. Thank you.
Thank you. That's awesome. I love my fans. Right? That's great. That's great.
And I'm one of your biggest fans.
Excellent. One of the things that you're working on that's becoming a bigger and bigger issue in nephrology is this conservative care. Is that, and I think we have done a bad job in nephrology of looking at this great therapy of dialysis, but not answering an important question of who benefits from that.
I think that's a great question. I mean, we've been very fortunate that end-stage kidney disease or advanced kidney disease is a condition in which in the US overall we have universal healthcare coverage,
yes.
But in some ways that has led to some inertia in looking for more alternative patient-centered approaches for handling advanced CKD, such as conservative care that's really should be driven by patients' values and preferences.
And one of the things that when we've compared dialysis to conservative care, how little duration of life we actually gain from hemodialysis. I know there was a study in I think it was in KI last year from Tamura, which was depressing, right?
Yes, yeah. I mean, these are very important points. As we look at a lot of our global colleagues, many of international experts have been studying the utilization of conservative care. They've published a lot of, I think, meaningful work showing the really marginal survival benefit or benefit in terms of other outcomes with dialysis with respect to less aggressive approaches like conservative or preservative management. But in the US, we still do have a paucity of studies looking at our populations. And so that's an area that we hope to fill with colleagues.
So you have a poster, your group has a poster at this session on cognition in conservative care versus dialysis. What were you guys looking at there?
Well, thank you so much for the opportunity to highlight this work. It was a team effort, so I want to give a lot of kudos to my co-PI, Dr. Cam Kalantar, in which we have a currently funded NIH R1 study called the Optimal Study, comparing conservative care with dialysis. And this is in collaboration with other institutions, UCLA, VA-GLA, VA Long Beach, Harbor UCLA, Memphis VA, and also UC Irvine. And I also want to give a lot of credit to my mentee, Dr. Yoko Narasaki, a postdoc, who led the analyses.
Mm-hmm.
But essentially, because dialysis has been the long-standing paradigm for advanced CKD progressing to ESKD, we wanted to look at the comparative effectiveness of conservative management versus dialysis. And we had the opportunity to leverage data from the National VA database. Veterans actually comprise 13% roughly of incident ESKD patients in the US.
Wow.
They are an important population that we care for, a vulnerable population. And therefore, we, using propensity score matching, looked at advanced CKD patients with the eGFR less than 25 who are either transitioning to dialysis or who did not transition to dialysis within 2 years of that index GFR over the period of 2010 to 2019. And we looked at the impact upon cognitive outcomes, including dementia, mild cognitive impairment, and an aggregated outcome of mild cognitive impairment and dementia.
So, I don't do a lot of geriatrics, and mild cognitive impairment, in my mind, that's just a spectrum. Is that just real mild dementia? Like, what does that look like?
Yes, yeah. So I think in terms of, we ascertain these endpoints using diagnostic codes, and so therefore we weren't able to apply.
This is really just kind of observational
Exactly,
data, and
yes.
in the VA system, these people get these types of testing done,
Exactly,
and
yes.
it becomes part of their medical record. So it's actually a great cohort to look at to be able to just do this kind of data.
Yeah, thank you.
So what did you find?
So, so notably, we started with a national cohort of about 90,000 U.S. veterans who with this advanced CKD with eGFR less than 25 over that time period. And then we looked at those in the dialysis group and those in those who did not transition to dialysis. We did propensity score matching on a lot of different variables to try to have a balanced cohort.
Yeah.
Although it's not a clinical trial, we're doing a pseudo-clinical trial trying to make a comparison between apples and apples instead of apples and oranges. And so they had somewhat balanced characteristics between the dialysis and non-dialysis group. And we found that across multiple primary, secondary, and sensitivity analyses, those who transitioned to dialysis had a roughly 35 to 40% higher risk of developing de novo or incident dementia, mild cognitive impairment, or a combined outcome of mild cognitive impairment and dementia compared to the non-dialysis group.
30 to 40% increase. So the question is, do you think it's causative? Do you think the dialysis is causing that? Or do you think the people that are progressing to dialysis tend to be sicker, have more vascular disease, and are going to be more prone to that, whether they did dialysis or not?
I think that's a great question, and we actually really hope that these findings can engender more discussion about this. As we've discussed before, as an observational study, we can't conclude causal relationships, but we do hope that this serves as good premise or preliminary data to do further investigation, looking at causality or mechanisms. But I think certainly in terms of biologic plausibility, with the hemodynamic shifts that we see with dialysis.
Right, we've seen MRI data showing loss of white matter. Like it does fit.
Yes, yeah.
But it's also concerning.
Yes, yeah. I mean, dialysis is important in terms of it is life-preserving therapy. There are certainly patients who substantially benefit from dialysis, in whom it not only improve survival, but also other patient-reported outcomes. But there are segments of the population with advanced CKD who may not per se benefit, and who may not particularly have better patient-centered outcomes such as cognition, and those are questions that we need to tease out. Which patients are appropriate for dialysis? Which patients are appropriate for alternative patient-centered approaches?
And so before we started this interview, you were talking about some of the data from the CONVINCE trial, which is actually pretty interesting.
Yes,
so remember, the CONVINCE trial was the randomized trial of hemodiafiltration versus just conventional diffusive clearance with dialysis. And what did they find in the CONVINCE trial in regards to cognition?
So very exciting study. I think that has garnered a lot of attention in terms of comparing hemodialysis versus online hemodiafiltration. But essentially, in the study published by Rose et al., they found that with online hemodiafiltration, there was some improvement in quality of life, but particularly the cognitive endpoints. And cognition is a very critically important outcome to our patients in terms of their functional status, their quality of life, relationships with care partners.
It's one of the things that people are most frightened of dementia. It is a horrible loss. Now, can we read about that in CJASN?
Well, we'll see. I of course have to recuse myself from any submissions, but we hope that in some journal, I think the readership will have the opportunity to delve into the work, and hopefully this will inspire more work by other collaborators and colleagues in the field.
So let's shift gears a little bit. So now you've been the editor of CJASN for just over a year, about 15 months now, and what has been most rewarding about that job?
Oh my goodness, well, so many things. I really consider it the highest privilege to be able to serve my community and our field in this role. When I was a trainee, I actually was reading CJASN as my main curriculum, and to now have the opportunity to be able to give back through the journal and to work with a really talented group of editors and reviewers and our authors and readership and managing editorial team to really be a voice for the kidney community. I'm so grateful. And it's really wonderful to work with and get to know so many amazing people in our field through this effort.
Yeah, and then what's been the most surprising thing about the job? What did you not expect about being the editor?
I have a bit of a shy personality, so I tend to just put my head down and I think do my work. But I think through this opportunity, I think I've been so surprised by all the friendships and new collaborations and relationships I've developed. One of our major goals of CJASN is to really have a global reach, and so I think through this opportunity, I think it's been just a delight, and to be able to connect with more patient colleagues, allied health professionals, other nephrologists, non-nephrology physicians, locally and also globally. And so it's going to be a wonderful journey together, for the coming years.
You heard it here first. It really is about the friends you make along the way.
Definitely, yes, absolutely, yes.
Hey, Dr.
We
Rhee.
consider you a good friend, Dr. Topf, too.
Thank you for joining us for this interview with Nephrology Times. This has been great.
It's an honor.
Awesome.
Thank you so much.
Have a great meeting.
Thank you so much. Thank you, you too.